women who are breastfeeding because we don't have data about that. We have insisted with the company, not just Pfizer, but all the companies, that pregnant women and women who are breastfeeding should be included in the clinical trials from the start so that we have data to be able to make recommendations for the use in these groups. We also do not have data on the vaccine safety and efficacy in people below 16 years of age. We have been told during the meeting that we had on the 5th that the company is already planning or doing or starting studies to look at lower age groups. And when they come along and we have the information, then we will make the recommendations about the use for these groups.
Alejandro,
Yes.
I just want to jump in a little bit.
Yes, please.
I think you've made it really clear sort of what the core recommendations are, and I'm seeing a lot of questions coming up also about the use of the vaccine, about who's going to get it and which countries are going to get it. Alex, I wonder if we want to go to some of those excess questions, and we can certainly talk about some of the other recommendations that have come through from SAGE. They're very extensive and very detailed.
Of course, there are a lot of questions. Kate, you're right. I'm gonna read some of them. One concern is as well, do we have any updates on the variants and vaccine testing efficacy? As we've seen around the world, that the virus has been changing, so people are concerned whether those vaccines are still going to be effective with those new strains.
So,
Kate, do you want to start with that?
Yeah, maybe I'll start, Alejandro, and then I can pass over to you. So, when these vaccines have been developed and when they've been tested, they have been evaluated against a number of different strains of the virus. As I think everybody knows, viruses change all the time. It's not really a question of whether viruses change. That's a normal part of a virus. It's a question of whether the virus changes in a way that either affects the disease itself or affects the treatments, or in this case, will it affect the vaccines? So we've been hearing about a couple of variants that are emerging around the world for which there is concern about transmission, and the evaluation about whether the existing vaccines will be impacted at all is underway. But what I think we can say with pretty strong confidence is that we need to proceed, as quickly as possible with vaccination. The kinds of changes that there are being seen in these variants are not felt to be likely to change the impact of the vaccines. But this is we're in a dynamic space right now, and unless we have information that there are changes to the vaccines, that then certainly at the present time, we're going full speed ahead with the vaccines that have been developed. So we'll get more information, but there's no reason to believe at this point that there should be any impact on the vaccines.
I think that's the main message, yes.
Thank you so much. Thank you both. Here is the next question from a viewer watching us on LinkedIn. Conditions, is it safe for them to receive a vaccine?
Alex, can you just repeat it? We lost your sound for a little moment there, just at the beginning of the question.
Sorry about that. So a LinkedIn viewer is asking, what about people who have pre-existing conditions? Is it safe for them to receive a vaccine?
Do you want to take that, Alejandro?
It depends very much on the pre-existing conditions. I think what we have been clear about this vaccine is that anybody who has had a severe reaction, allergic reaction to any vaccine should not receive this one. That is one of the things. But if someone has an allergy to a food or to some other product, then we don't see a contraindication to use the vaccine. But we do have the recommendation to do the vaccination in a place where a severe allergic reaction can be treated effectively and immediately. Those would be the only things, because we have seen a number of reactions with the vaccine, and we are following the cases to make sure that they have been properly studied. I don't know if you have any other thing, Kate, that would be useful for us for this question.
Yeah, so I think the other thing is that, people who have underlying conditions, so people who have heart disease or underlying lung disease, people who have diabetes or obesity, we know that those are the people who are actually at higher risk of having a serious outcome from a COVID infection. And so for those, for the underlying conditions, those are actually the very people we want to be immunized. And apart from some very selected groups, people with underlying conditions were included in the clinical trials that demonstrated the impact of the vaccine against disease. So there's a very limited list of conditions for which somebody should not get the vaccine. And as Alejandro said, a really very limited list around only those people who have had a serious allergic reaction to an injectable product before would be excluded, or if they have a known allergy to something that's in the vaccine. But these vaccines, it would be very unusual for somebody to have a known allergy to what's in these vaccines. And then the second thing that Alejandro mentioned before is we just really don't have the data on whether or not women who are pregnant, whether there's any concern for them. But I do want to emphasize there's no reason to believe that these vaccines would be harmful to a pregnant woman or to the baby that she's carrying. So for women who are pregnant and who are in the highest groups of recommendation, especially those who are health workers, we are recommending that they have a conversation with their provider and discuss what her risk of COVID is. And if that is a significant risk, we think they can go ahead and decide to go ahead and vaccinate. So those are really a very limited list of conditions for which people shouldn't get vaccinated. People who have HIV infection should go ahead and get vaccinated. Anybody who has, especially those conditions that would put them at risk of serious disease from COVID, should go ahead and get vaccinated.
Thank you so much,
The,
Kate. Oh, please go
the,
ahead, Alejandro.
the other group that has come up are people who have had facial paralysis. And although the vaccine has been found related to some of these cases, there's no real association shown before. So anybody who has had a facial paralysis can also be vaccinated without any problem.
Thank you so much. There is another question. How about those who had COVID infection and recovered? Should they receive a vaccine or wait?
Do you want to go ahead and take that one, Alejandro? It's part of the recommendations.
That is one of the main recommendations. We feel that people who have had COVID uh, diagnosed with a PCR test, I mean that we have an antigenic test, should not be excluded from vaccination. We do not know how long the natural infection protects anybody. We now have data up to 8 months from a paper published yesterday, but we do not feel that this is enough to exclude the people from vaccination. On the other hand, if someone has been infected and would like to have a solidarity effect and wait a bit for the others who have not been infected to be vaccinated first, then that is a delay that each person can choose to take so that there's more vaccine available for those who are still at risk of getting a severe infection and dying from it.
Yeah, so just
Kate?
to add to that, it's absolutely not necessary to get tested in any way before getting vaccinated to figure out whether you've had or haven't had COVID. We don't recommend any sort of testing in that way. But if you happen to know that that you actually have had COVID, we're still recommending that you go ahead and get vaccinated. But as Alejandro said, in this period where there's really just it just getting started with the vaccine, and every country is trying to deploy that vaccine to the very highest priority groups, there is much less likelihood of somebody who's actually had COVID disease, at least in the next 6 months, to get it again. So an individual might just decide, that they'd prefer for, the person that they work with to be first in line ahead of them. But we're not suggesting that programs actually exclude or delay the vaccination of people who have had COVID disease.
Alex, if I may just say, Sage has made a document that has been now translated to 5 different languages about how we have prioritized the group that should be vaccinated. This is based on an ethical framework about who do we feel should have access to the vaccine in sequence. And I think that might be interesting to your viewers. That has been published and it's in the WHO webpage, and it's a map in which we have 3 different ways that the disease is moving on in different countries, and which are the groups that we think should be vaccinated first. One, for reasons of security for them if they are exposed, then for reasons of age and comorbidities, as Kate was saying, and then finally the rest of the population when we have more information. Those documents are accessible in the WHO webpage, and your viewers might like to see them and read them to see what we have been already saying about these issues.
Thank you so much. Thank you both. Here is the next question coming from Andrew Dugan, who is watching us from Facebook. What is the implication of mixing different first and second stage vaccines?
So that's a great question. Maybe I can take that one. So as mentioned already, WHO has authorized in a regulatory way one vaccine to date, but we will have other vaccines that are going to come through that regulatory pathway. And SAGE is going to look at those vaccines also and provide specific recommendations. And already in some countries, there's more than one vaccine that's in use in the country. So the question is really, I think your question is what we call a mix and match question. Can you get your first dose with one product and then get your second dose with a different product? And the answer to that is we have no data on mixing and matching. And so for the recommendations that we've come out with for the Pfizer vaccine is that your second dose should also be of the Pfizer vaccine if you got your first dose as the Pfizer vaccine. And the same will likely be true of the recommendations for the other vaccines as they come through SAGE. We do know that there are some really practical considerations and some countries in an extreme circumstance where somebody shows up in a clinic and they receive one vaccine for the first dose and they just don't have that vaccine in the clinic anymore and they don't expect to be getting it. So the choice is really, do we give no vaccine, second dose of vaccine to the person, or do we give them a different product? We know that some countries are recommending to go ahead and give the second dose of a different product. This is a really important area of research where we want the information about this, and we will be prioritizing that kind of research so that we actually have some data on which to actually make that recommendation. But it really points out that when we're making recommendations for use of vaccines, we really want to follow the data as best we can, but at the same time, recognize that there does have to be flexibility to deal with real world situations, and people are doing the best they can based on the experience with other vaccines.
And
Thank you
Kate,
so.
sorry, Alex,
No,
maybe
please
here
go
we
ahead.
should also say that we don't recommend for now giving this vaccine with any other vaccine at the same time because we don't have that information. So we recommend that you wait for at least 2 weeks before receiving any other vaccine after you receive the COVID one.
Thank you so much. Here is the next question coming from Anita Powell, who is watching us on Twitter. How African nations, particularly the lower income ones, will get equitable access to the vaccine and how quickly that might happen?
So from
That's
the
Kate.
very beginning, from the very beginning, for WHO and critical partners that we have, UNICEF, Gavi, CEPI, from the very beginning and is absolutely consistent, is the only way that we're going to end this pandemic is for everybody to have access in all countries to these vaccines. So no country is going to be safe until all countries are safe. This virus crosses borders. It doesn't recognize that there's a border. And so just immunizing in a small number of countries or a limited number of countries is not going to keep people in those countries safe, because there are always going to be some people who are unimmunized or can't be immunized. And if this virus remains as a widely circulating virus, it puts everybody at risk. The way that countries that are less able to themselves afford the vaccine, we've established a way to deliver vaccines to all countries, and it's called the COVAX facility. And this is basically an entity to aggregate the demand from all countries. So we've got 190 countries and economies that are around the world that are part of the COVAX facility and have agreed that they will be procuring vaccine through that facility. It represents over 90% of the world's population. And the reason that's important is the facility has committed to an equitable and fair allocation of vaccine. And part of the facility, where the money is coming from to actually buy the vaccines, for countries that can afford it, they're paying for the vaccines that are coming through the COVAX facility. For countries, 92 countries, that are less able to actually purchase these vaccines on their own, from their own domestic funds, there are donor funds that have been provided. We need about $7 billion in order to deliver enough vaccine to these countries through the end of 2021. And the facility has already raised about 6 billion of the $7 billion. So the facility has access to over 2 billion doses of vaccine. And we will start to deliver those vaccines probably by the end of January, and if not, then certainly by early February and mid-February. So that's how countries in Africa and South Asia and other countries around the world, of these 92 that are less able to afford vaccines, are actually going to get vaccine, and laying them out and rolling them out at the same time that high-income countries are rolling out their vaccines.
Thank you so much, Kate. While we were talking and explaining how we will achieve global access to COVID-19 vaccine, the question came up, at what percentage universal herd immunity would be achieved with COVID-19 vaccine?
Oh, this is such an important question and a really great question. So for those of you who don't know what herd immunity is, maybe I can just say a couple words about that. Herd immunity refers to the reduction of disease risk among people in the community who actually aren't vaccinated. So they should have the same likelihood of getting disease as anybody living in a community where there's no vaccine being used. But people who live in a community where there's a lot of vaccine being used, actually, even if they're not vaccinated, have protection against the disease. And they have protection not because they individually are immune, but it's because they're living in and amongst a large number of people who are vaccinated. And so if the pathogen, if the virus comes into the community, it simply can't move in the community, and ultimately it dies out. So that's what herd immunity is. And the question is, well, what fraction of the community actually needs to be vaccinated or immune in order to create these blockades for the virus and where it can't really move around the community? For COVID, we don't know what the answer is to that. We don't know what the fraction of the population is that has to be vaccinated, but we have some idea about what it might be. And the reason that we have some good guesses about what the fraction is that we've studied a lot of diseases that are vaccine preventable, and we know some of the characteristics that determine what fraction of the population has to be immunized. So based on the characteristics of the vaccine and its ability to actually stop transmission, meaning if I'm infected in my nose, infecting you, my neighbor or my family member. So that's transmission. We don't know whether these vaccines actually alter transmission. We know that they protect against disease, but we actually don't know yet to what degree they prevent against either acquiring the virus, of it replicating in the nose, and of it being able to transmit to somebody else. So we really need that information. But when we make some assumptions about how strong the effect might be of these vaccines, we think that the proportion of the population that would need to be vaccinated is something around 70% or more. For measles vaccine, it takes over 95% coverage in the population in order to achieve herd immunity. It's a really difficult one to get herd immunity on because measles is so infectious. It infects so many other people who are non-immune. So for this virus, for coronavirus, we're still in early days, and we're going to have to see what happens. We're going to have to actually observe what happens in communities where the vaccine is being rolled out.
Kate, the other question that's coming up in the chat is, how long will the effect of the vaccine last?
So again, we're in the early days of using these vaccines. In the clinical trials, which began in the spring, we will learn from those, from continuing to follow people in those clinical trials, how long the immunity lasts, at least by testing the blood for immunity. And we don't know the answer to that. Our hope and expectation is that there will be durable immunity. We're also looking at people who were naturally infected with COVID-19, and that will also give some indication of how long natural infection immunity lasts, and perhaps will apply also to vaccine-related immunity. So this is, again, one of the areas where it's too early to tell at this point, and we will continue to follow people who were in clinical trials, and we'll be following people who are getting the vaccine in general use for frankly for years to come, so that we can get the answer to those questions and then adapt the policies on vaccination according to the evidence around whether or not people need more doses apart from the 2 doses that they're getting initially.
Thank you so much, both. Quality of vaccine be the same worldwide?
Can you just repeat the question again, Alex? Again, we lost your sound just at the beginning of the question.
Oh, apologies for that. So the question was from a LinkedIn viewer, whether the quality of vaccine distributed worldwide will be the same.
So again, I want to come back to the regulatory approval. So for any vaccine that WHO has reviewed and has authorized, you can be confident about the quality of the vaccine. These vaccines are being manufactured in many different countries. And for every vaccine, we actually evaluate the manufacturing in each of the manufacturing plants where the vaccine is made. So from a WHO perspective, we will only speak about the quality, the safety, and the efficacy of vaccines that we've had a chance to look at the data on. And that's why it's so important for all manufacturers to commit to and follow through on submitting their data to WHO so that it can be reviewed and we can give that confidence to the world, frankly. So given that vaccines are provided to millions of people, and in this case, hundreds of millions of people, the standards on the highest standards that we have on vaccines are maintained for these COVID vaccines, and we won't compromise on that. So that's the assurance that we can provide. And when you see that a vaccine has been WHO authorized, you can have that assurance.
Thank you so much, Kate. Alejandro, do you have anything to add?
No, that's a WHO policy that we all follow. But maybe, Kate, you could just explain what the pre-qualification process is?
Sure, I can do a little bit of that. So WHO itself is not a regulator. We're not a country regulator. But what we do is we are trying to provide a review of the same information that national regulators receive. And in doing so, and in also looking at the manufacturing facilities where vaccines are made, what we are saying to the world when we either pre-qualify a vaccine or we issue an emergency use listing, which is a more limited amount of data. And that's how all of these vaccines are coming through the regulatory process. What we're saying is we have both looked at the data itself, we've looked at the manufacturing, and we have worked with a national regulator in the country of manufacture so that we're reviewing with them the data. And that means that for UNICEF that is buying vaccines, so any of the UN agencies that are buying vaccines, and any other national regulatory authority, they can rely on the review that WHO has done and move their processes more quickly. But it really is the responsibility of every country's regulatory authority to finally make the authorization for a product to be used in the country itself. And they can certainly leverage and use the information that WHO has provided to verify the quality of the data and the manufacturing.
Thank you so much, Kate. Thank you, Alejandro. There is a question from a few viewers. What is the difference between Pfizer and BioNTech vaccine in comparison to the Moderna one?
So both of these vaccines are what are referred to as mRNA vaccines. There are basically four ways that vaccines for coronavirus are being made. One is that the vaccine provides the instructions to our own immune system in order to produce the part, the small, tiny part, just a very small component of the viral particle against which the immune system will react. That's what these mRNA vaccines are. It's like saying, I don't know if this analogy is going to work, but it's like saying if you wanted to have a cake for dessert for dinner, you could do one of two things. You could either go out and buy the cake, or you could have the recipe for the cake. And if the cake is the equivalent of the particle, the subparticle of the virus that we want in the body so that our natural immune system can respond to it and therefore practice in developing the antibodies that in the future, if you ever were truly exposed to the coronavirus, your body would already have the fighters that recognize that virus to kill it right away. So so the mRNA vaccines, Moderna and Pfizer, are providing the recipe to our body, and our body goes ahead and makes the very a tiny component of the virus. We don't produce the virus; it's just the little bit of the target, so that our immune system then sees that target and develops antibodies. So these two products are mRNA vaccines. They're using the same approach to develop the vaccine. And this is the similarity between them.
Thank you so much, Kate. There have been a few questions about side effects of those vaccines.
Alejandro, do you want to take the question around side effects of the vaccine?
Um, the main side effect that we have been worried about and that the company has been following, and that the countries that have been implemented the vaccine have set up systems to follow up, are the severe allergic reactions. I think that is why our recommendation says that where the vaccine is given, you have to have all the facilities to be able to treat anybody who develops in the first 30 minutes after the vaccination a severe allergic reaction that requires treatment. On the other hand, the other side effects that we're following, as I said before, are these facial paralysis, of which there have been some cases that have been reported. Uh, but so far, the other ones have been mostly that your arm where the vaccine is given hurts, that you might have a bit of fever or not feel very well in the next couple of days. But all of these have been transient, and they have not been something that would be considered as contraindication to receive the vaccine for other groups. Um, I think this is common with the things. If you have ever received the vaccine for influenza or this new vaccine for shingles that is also being used currently, you will have more or less the same type of side effects. And interestingly, the side effects in the older population have been less severe than in the younger one, which also indicates that there might be something related to response there. Um, I don't know if there are other, Kate, that you would add to this
The only thing I
contraindication.
would say is uh, I think it's really important that people understand that when you do get vaccinated, it's not uncommon, as Alejandro just said. You will very likely have a sore arm, with especially with the mRNA vaccines, which stimulate a very robust immune response. A significant proportion, up to a third of people, are going to get a headache or not feel well for perhaps 24 hours. The data says sometimes up to 48 hours. So I think also setting expectations that what is happening when you get those symptoms is it is your body's immune response that is actually turning on. It's why you don't feel well. It's because your immune response is actually doing something here to having received the vaccine. So especially if you can certainly take anti-inflammatories, paracetamol, ibuprofen, to make yourself feel better. But I think just having that expectation that you might not feel at your best for the first couple of days, but there's a reason for it, and something good is happening in your body when that's happening. So I just think that as people are more prepared to have that expectation, maybe they're worry less when they have some of those transient, they will go away, transient side effects. And I just think that the more people are prepared, the better off they are with having that information.
And that includes also the facial paralysis, which have been reversible. There's no long-term lesion in that sense. Yes.
Thank you so much. Alejandro, maybe you can take this question as well. What is the protocol if the second dose of vaccine is not available?
Well, that we would then say that you have to wait until the vaccine becomes available to have it. We don't recommend second dose of another vaccine, even if that is available, because then we don't know exactly what the process is. But if you have received two doses of any vaccine, we don't recommend that you receive any more in afterwards.
Thank you so much. You explained that for Pfizer vaccine, minimum age is 16 years old, but a lot of our viewers are asking what's the plan for younger children and babies?
So maybe I can just take that there. The research is ongoing. So, and we say research, it means, generating new knowledge. So the clinical trials until now excluded people who were under 16 years of age, but there are the development of studies to look at the vaccines in kids who are 12 to 16 years of age. So there should be information coming in the future. What Sage also said, though, is in general, we do not recommend, because we don't have any data, we don't recommend the vaccines for people who are under 16 years of age. But there are situations where an individual practitioner, in consultation and discussion with the family, for a child who has a serious underlying medical condition, and that would put them at significant risk of a very negative outcome from COVID, might choose to go ahead and use the vaccine. We're not recommending that. We're not saying go ahead and do that in all circumstances. But the words that Sage used was, in general, this is not recommended for people under 16 years of age. There may be a limited number of circumstances for a very vulnerable child. Maybe, if it's a 15-year-old, are we really going to, as an individual practitioner, really going to withhold the vaccine from somebody who has a serious underlying condition, for which the risk of COVID may far outweigh the unknown risk or the unknown benefit of a COVID vaccine?
Thank you so much, Kate. I think this is a question that you may take. A lot of people are afraid to receive the vaccine due to a lot of information circulating on social media. What is WHO recommendation to promote a positive vaccine acceptance culture in countries?
Oh, I love that question, because frankly, so many of you who are listening to this are part of that solution. The first thing is that getting credible information is the most important thing. We know, not just on vaccines, but for all kinds of things, we have a social media that is absolutely full of misinformation and blatantly misinformation, not just a little mistake, but something that's put out there that is completely inaccurate and completely wrong. So the first thing we would say is to get your information from credible sources. That means WHO, it means your government health department, it means examples like the UK Public Health Department, the US Public Health Department. All of your countries have public health departments or ministries of health that provide credible information. The second thing that we are doing at WHO is we are working very closely with social media companies to assure that when misinformation is put up on social media, that there are ways that that information is identified and it cannot be further distributed. And Alex, I wonder if you want to talk a little bit about maybe some of the other ways that we're working with social media companies. But the third thing is that where people get their information from is from who they trust. And often who they trust is their own practitioner, their own medical practitioner, if they have a regular doctor or a nurse. But they also trust their family and their friends. And you are family and friends of so many people. And so assuring that you are well informed, that you have scientific literacy, that you're not distributing information that is not credible. And one of the things I would really warn people about, and it's what I have adult kids and I say to them also, if you hear something that seems pretty outrageous or seems, pretty astonishing, the
Ask.
likelihood is that it's not accurate, and check it out before you start pushing it on to somebody else. Nobody in the vaccine world, we all have kids. We all have immunized our own kids. We all immunize ourselves. Our interest is in providing safe, effective vaccines that can save lives and take care of people. So if you hear something that just sounds like really outrageous, please don't push that on until you've actually verified it with a credible source.
Yeah.
Thank you. Thank you so much, Kate. And I'll use the opportunity to remind the viewers that we've been working with social media platforms. The list is long, so I'm not going to name them all, but that when you search for information, vaccine related information, even before COVID pandemic, you are directed to a reliable source, including WHO, but also national health authorities based on location where you're at. We're also working together with them to spot all this misinformation circulating and to give you the answer based on science and evidence that we have. So as Kate mentioned, before you share article and those misinformation, check the source, check the date of information, check that you're not biased, turn to fact checkers, or simply go to the National Health Authority or WHO social media channels or website to check if this information is true and reliable before you pass it on. And even our friends and relatives are seeing a lot of information, and they share it with us with the best intention, but not necessarily is always a true information. So don't feel ashamed even to check on your friends and family members. Um, Before we end, I would like to thank you so much for answering all those questions. But I would ask you maybe to summarize once again which vaccines have been listed for the use by WHO, and what are the recommendations at the moment, given the current data we have for COVID-19 vaccine use.
So at the moment, there's a single vaccine, a single corona vaccine that has been listed by WHO. It's the Pfizer-BioNTech vaccine for emergency use listing. We are in active review of the data on other vaccines, and we do expect to be emergency use listing additional vaccines in the coming weeks and the short next months. So this is not the end of the story. This is the first one. The recommendations on the Pfizer vaccine is for those over 16 years of age or older to get 2 doses of vaccine separated in time by 21 to 28 days. There are some small numbers of people who should not get the vaccine. Again, we won't repeat what those groups are. But this vaccine is in short supply, as all of the vaccines will be for the coming months. Supply is going to increase. And so it's really important that countries prioritize who are the highest priority groups to get vaccinated to have the quickest impact. And that includes health workers who are at high or very high risk of coronavirus disease, and those who are older adults. And the reason we say older adults is that according to different countries and what's going on in different countries, there's no one cutoff of age that applies to every single country. In some countries where we see that increase in risk is for people over 65. For other countries, we see the risk increase at a slightly younger age, 55 or 50. So we leave that up to countries to look at their own data to decide what is that actual age group. So those are the main recommendations that we have. We are standing behind the evidence on the safety, recognizing that there have been these serious allergic reactions in a small number of people. We are continuing to monitor that on a daily basis. And the recommendations do change according to the new information that comes out. That's why there have been now restrictions on people who have a history of having allergic reactions to injectable products. And that's exactly what you would expect from us, is to continue to update data and recommendations when we learn something new. And so I know some people feel frustrated in a way, or wonder why recommendations from today may change a week from now, 2 or 3 weeks from now. But frankly, it's exactly what I would expect of scientists, is give us the best information that you have and as you continue learning more, adapt what those recommendations are. So that's where we're at today, and we're really looking forward to reviewing in an ongoing way, which we've already started, on additional products, the Sinopharm product, the AstraZeneca product. We are underway in the review of those products. We are engaging with the Russian product. We're engaging with the Moderna product. We're engaging with any manufacturer who has vaccines that are coming through efficacy trials. We are engaging with them. So we have 15 manufacturers that have contacted us, believing that they have the data that are required to meet these highest standards. And we're under review and in discussions with all of these manufacturers.
Thank you so much, Kate. And last but not least question, even though there are vaccines for some and some people have been vaccinated, we still need to practice proven preventative measures. Can we explain to viewers why?
So there are a couple reasons for that. First of all, there are very few people who have been vaccinated in our communities, right? And a limited number of countries so far. The second is that while there continue to be people who are unvaccinated, and while we do not have information on whether or not these vaccines interrupt the infection in the nose, even if you're vaccinated, it may be that you can become infected, you may not get disease, but you can pass it on to somebody else. So we are in the very early days of vaccine use, and now is not the time to pull back from the interventions that we have already on physical distancing, wearing masks, limitation of the number of people that you have exposure to or that you are exposing. So for the foreseeable future, we really need to continue and add vaccines to everything we have in our toolbox. And I want to emphasize today was one of the highest days of deaths reported to WHO. We are still in a very, very bad situation with this pandemic, and there's urgency to roll out this vaccine in order to turn the tide on this pandemic. But now is not the time to be stepping back from the things that we're doing. Instead, it's time to recommit to doing those things that we can do to keep ourselves safe, keep our families safe, and keep those around us safe.
Thank you. Thank you so much, Kate. Alejandro, any final words from you before we close?
No, I think that Kate's message about the need to maintain all the measures that we have to protect ourselves, regardless of the incorporation of the vaccines, is one of the most essential things that we need to say. Thank you.
Thank you so much. I thank you both for your time, and I thank all our viewers watching us from Nepal, India, Peru, Argentina, Bangladesh, Spain, UK, US, Saudi Arabia, South Korea, Indonesia, Laos, Vietnam, Greece, Italy, Philippines, Trinidad and Tobago, Finland, Bahrain, Botswana, Romania, the Netherlands, and many, many others. Please follow our advice, stay safe, and we'll keep you posted about any new evidence and information we have about COVID-19 vaccines. Thank you and goodbye.